important. You probably know that the community blood bank is low on blood supplies, haven't had as many donors coming in because of the COVID fears. And so it's here today. It's over in the health education building from the university. It's open from 9 to 3. Appointments are required. If you go to Save a Life, all one word, savealife.com/coronavirus, you'll get details. You can get an appointment. Can't tell you about how important that is because blood does save lives. So, Doc Hawk, where are we this morning?
Yeah. I think we were getting concerned because the past couple weeks our numbers have been pretty low, as far as in the 20s or even lower. Earlier this week we had a couple days where we had about 31 or 32 in the hospital. We've certainly had some discharges now, and that's a good thing. Our numbers of admissions every day are about stable, about 4 to 5 a day, but we've had more discharges. So today, our numbers are 24 inpatients.
Which we're going to have a celebration about. That's a cause. That's good news. Mm-hmm. We'll have to see what happens as society opens. We know that there are more and more positive tests being reported.
Yeah.
We don't know how many of those would have been positive before if we'd actually had tests. So
Right.
Hard to know what all that means.
Yep, and 9 of those are in the ICU. So again, some of these patients that have been here a long time contribute to those numbers. So I think we're doing very well. We want to get those patients discharged as soon as we can. But as you said, as we start to open up and loosen restrictions, it's going to be vitally important to watch how the numbers of total infections are, as well as hospitalizations.
I guess, and talk a little bit about the impact to hospitals and to our hospital from the coronavirus. And I know one of the interesting things, we cut all the surgeries, we stopped all our clinics, we did that really early, but we haven't had the wave like New York. So not only do we lose some revenue sources, we never built back any of it.
Yeah, we really got hit twice, financially. Although it's a good thing we haven't had the big surge.
It is a good thing, no question about it. We're not asking for it.
One thing, just to keep in perspective, there's a lot being written now about healthcare and hospitals, and you referenced some of that. Just to put it in perspective, the margins in a hospital are pretty slim. The advisory board, which is a group that reviews and tries to predict the future, and as well as rating agencies like S&P and Fitch, say the average margin for hospitals is 1.7%. To put that in perspective, if you make $1,000 of gross charge, you're going to have $17 to the bottom line. So given that framework, we can't stand a big disruption. Otherwise, it wrecks the finances of a hospital. Unfortunately, we've had a big disruption. This pandemic is probably the biggest disruption you can see. Across the country, those that in peer hospitals that we talked to, they were predicting early on about a 40% decline in gross charges for the first 3 or 4 months. Some are saying 20% for the next 12 months. We don't know, but it's going to be a significant impact. So it's a big challenge.
And we know that coronavirus has made people fear that hospitals are no longer safe. And it's funny, not funny, but when you close clinics like we did, or we close the operating rooms, you would think, man, there's going to be a huge surge going to the emergency room. And the truth is, ER volumes are down. I think that's the canary in the coal mine.
It's kind of a leading indicator.
It is. Well, there is no world in which you can close clinics and think that you're not going to have more patients in the emergency room. But ER volumes are off across here and across our city and across the country by 20 to 40%. Even though people can't access their primary care physician. Telemedicine is going to help, but it didn't help for the first few weeks, yet people didn't come. And what we know to be true is that folks are having heart attacks and strokes and bad outcomes at home because they're afraid of going to the hospitals. Yet hospitals can be some of the safest places because of all the infection control that's in place. I mean, if you think about it from a pure patient safety standpoint, I would go so far to say as we are probably safer today than we were for a patient even before the coronavirus because of all this infection control work that has been done in our re-engineering. So I think we can't say it enough, and it's not because we're trying to just make money, because we don't make a lot of money. It's really because we're in the business of taking care of people. And if people are having bad outcomes at home, that is not the right way to fight coronavirus. So there's been federal dollars that have come in, and we're going to turn to Senator Moran in just a moment, because that's a really important aspect. But a lot of that has to be paid back.
Well, there's probably more categories. There's 2 significant categories. There's federal grant money that does not have to be paid back. And then there's been advanced payments from Medicare, of Medicare dollars. That has to be paid back. So for us, and for any hospital, what's more important for sustainability are those grant dollars. And we have received some of that.
Yeah, which has been a big thing. And so we're going to thank Senator Moran, as we know he was instrumental in helping put that program together. Senator, welcome back. Good morning. Are you in the basement, or you're in D.C. right now?
Doctor, I'm back to the basement, having returned. It starts all over, apparently.
2 weeks.
Yeah, here we go again. Great to be with the doctors and with Mr. Gaston. Thank you very much for allowing me to join you on this Friday morning. It is pleasing to hear what you say is taking place, pleasing to be at least confirm something that I have been telling folks not only in Washington, D.C., but in Kansas, that perhaps we can help lead the opening of our economy by the return of hospitals and healthcare providers to something much closer to normal. And while you speak about what's transpired at KU Health System, hospitals across the state of Kansas and around the country have experienced the same. And then you have physicians' offices and dental practices that virtually no business. And it seems to me that this is a place, because of the capabilities of our healthcare delivery system, that we can be most assured that it's the safest to return to. So I hope that we begin to see the revenues that come from patient care return to our healthcare delivery system, because, as you said, our hospitals in particular, but healthcare providers generally, hospitals in Kansas, there's about 122 or 3. Unfortunately, that number has declined in the last several years, and most, with maybe no exception, survive on the smallest of margins. When I talk to Doug's counterparts at a hospital in Kansas, I often say, well, so are you in the red or the black? And over the years, the answer to that question has been, well, it depends on what day you ask. So margins are a challenge. A significant part of hospital revenue in Kansas comes from Medicare or Medicaid, 2 federal and state programs. And those programs do not reimburse at the cost of the service provided. So hospitals are always trying to find something that helps them make their books balance and try to find a payer mix, in other words, insurance, Medicare, Medicaid, private pay, that allows them to get those margins where they have a future. The federal government has responded. I mean, as we've talked before, we're on what I call 3.5 phases of federal legislation. The CARES Act probably is the most significant for hospitals and healthcare providers. And we've set aside in that CARES Act $100 billion. Took me a few days to be able to get the word billion out of my mouth. I kept saying a million, but $100 billion to help healthcare providers across the country. We've delivered money in 2 tranches from that fund. The first one, $30 billion of the $100 billion. The second one, $20 billion of the $100 billion. The first tranche was based generally upon Medicare reimbursements. So if you were a hospital or a healthcare provider that received lots of Medicare patients, that you received money for in the formula that was rewarded, or that the money you received was based upon your Medicare caseload. The second one was more Medicaid, helping, for example, our friends down the street from KU Health System, Children's Mercy, who has very little Medicare patients, if any, and a lot of Medicaid patients. So each hospital was affected differently in how that money was distributed. And then just in the last week, we've been able to announce additional dollars coming from the Department of Health and Human Services, $18 million to high-intensity COVID-caring hospitals, and $382 million to rural hospitals. Those numbers are just for Kansas. So there is significant, that is, those dollars that I've mentioned here are grant dollars. There was, as Doug indicated, hospitals could receive 3 to 6 months of their Medicare reimbursements in advance, trying to help cash flow, and many hospitals did. Doug, I encouraged hospitals in Kansas. Many of them were worried about having to pay it back, didn't know whether they would have the Medicare revenue to do that. I encouraged them to take the money, sock it away if at all possible, and use it, of course, if necessary, but there is talk among members of Congress about some level of forgiveness of that advancement. So that's a fact yet to be determined, I assume, based upon the financial condition of our hospitals and the COVID crisis, that the magnitude of it as we continue weeks and months ahead. And finally, I would say last week when I was on your show, I'd hoped to be able to indicate we'd had a victory in regard to particularly small and rural hospitals in Kansas and across the country. The PPP program, I couldn't announce it last week. I couldn't announce it last week, but today it's in place. So businesses were able to get a payment, a loan, go to their local bank, go to their local lender, borrow money based upon their payroll, use that money to make payroll, and if they did that over a period of time, that loan would be forgiven. It's an SBA guaranteed loan generated by local lenders, and it was very popular and valuable in Kansas and across the country, but we had a glitch. Hospitals that were county, city, or district were considered political subdivisions and not qualified. And so shortly after we got off the program, certainly by Monday, we were successful in getting the Treasury Department and the SBA to issue new guidance to indicate those county, city, and district hospitals, which in Kansas, again, 120 hospitals, 60 of them would qualify for having less than 500 employees, a criteria for this PPP program. But about half of those were ineligible because they were political subdivisions, and we fixed that. So it is a significant benefit to hospitals that are important to all Kansans and important to the University of Kansas health system to keep those doors open as well. So that's a bit of a healthcare update. I would say that the unemployment rate was announced today. My concern and care for people who are unemployed, that rate hit 14.7% as announced this morning by the U.S. Department of Labor, and 20.5 million people unemployed. So we usually talk healthcare on here, but significant consequences to our economy and the well-being of people and their families.
Well, and certainly unemployment and healthcare get tangled up pretty fast. So thank you so much for your leadership on those issues. The PPP program is really good news, and I'm hoping about that, not having to repay back all those Medicare dollars, Doug, because when your margins start at 1.7% and your volumes are down, you're trying to keep your people employed. Not a lot of spare dollars to pay stuff back, just to be honest.
Yeah, and we did take advantage of that, so we have some of those advanced payment dollars.
Yeah. So questions from from the media and from others out there.
Yeah, Mr. Gaston, this is Mike Sherry from Kansas City Public Television. I kind of wanted to look at the other side of the ledger, I guess. My understanding is that when you're looking at decreased revenues, you've also had to make some pretty substantial investments in lab equipment to handle the additional testing. I don't know if you can drill down that far in terms of how much you've had to spend to buy new equipment and everything?
Yes, surprised and shocked that I got the first question, but I'll try to answer that. So I thought you guys might ask me something easy, but yeah, I think I can attempt to answer that. What you mentioned, lab and testing, was a significant investment. We also reconfigured parts of the hospital to add beds. The ambulance bays were changed, and you guys can probably talk more about that if needed. We really ramped up our purchase of supplies to treat these patients, the movement into telehealth and all the technology that goes with that. Dr. Stites had a goal to increase telehealth before this crisis hit. I think he achieved his goal in the first 2 months.
That's my goal.
Those were significant investments, just to name a few. The last I looked at that, those dollars were approaching probably $10 million. So at the time when revenues were declining, we were spending money to gear up to treat these patients. So that's the right thing to do. It's the right thing to do.
But we had our base rate of spending, and we didn't, unless you wanted to not have as many employees or not buy equipment, but we had to actually go above that in order to prepare. So
I will say that many hospitals really had a shortage of supplies. Our supply chain people have been tremendous, working virtually around the clock to put us in good position. I think we've gotten there. So
I think so. I think we had a few Saturday night, late night, or
Yeah.
early morning phone calls trying to determine if a supply offer was real or was one of those maybe not as high quality masks or whatever that,
Yeah.
that did we do have to thank our supply chain folks. Next question.
Hey, this is Lucky Kid from Anast Radio in Hutchinson, and this is probably for Doug Gaston. You talked about the kind of the financial situation impacting KU Health. Any comparison, say, between what's going on, seeing at the Kansas City operation and your operations around the Great Bend area?
I don't know that I can talk specifically about Great Bend. I mean, everyone's had some impact. I think we probably have had maybe a bigger impact here just with the population density we have here in the Kansas City market. Again, you would know more about that.
Folks out there, but there is an impact everywhere because everybody had to cut. The problem is you had to cut surgeries and you had to cut ambulatory visits.
And
they
we're all
did
part of
that
the
there.
same system, so we're
Right.
all in the same team here.
So we all lost revenue. So everybody had an impact. It's not like we're not going to keep Great Bend or Pawnee or obviously Hayes open or any of those things. But everybody's suffering the impact. And so one of the strengths of having a system is you try and handle that across the entire organization. But everyone did. And just to follow up on that, Senator Moran, I know that rural healthcare has been a particular interest of yours, and I'm sure you're talking to CEOs and people, leaders within rural hospitals frequently. I bet you're hearing the same story of the impact of cutting volume and not having cases there.
Steve, I might add a comment to that. With Senator Moran's help, we got something passed to help rural hospitals, and I'm not positive in my number. I need to check myself here, but I think Great Bend, for example, received about $3 million from that program.
That's a big deal.
That's really needed, and particularly in those communities. But it was, his heavy lifting that really helped get that done.
Senator, are you out there?
I'm glad I had my mute on so that Doug could compliment me in the absence of me being heard. So that worked out well. Thank you, Doug. Those hospitals are hugely important to the communities they serve. And the numbers that I talked about, particularly this PPP and the rural aspect, again, $400 million just since May in a HHS grant. $380 million of that dollars went to rural hospitals, places like Great Bend, Larned, Hayes, et cetera. So it is, and certainly not just the ones that are part of the KU Health systems, hospitals across our state. And as Dr. Stites indicated, those hospitals, they desperately need the revenue. You cannot stay open based just on government grants and loans. And as the state of Kansas opens its economy, people are less restricted. Again, in a responsible way, out and about, I would indicate, again, this is healthcare providers. I'd leave this to the experts on this program, in this press conference. But it seems to me that one of the places that we can begin to start saving our rural healthcare financials is by people being able to return to those procedures that they have been avoiding or delaying. Those opportunities now exist. And the key in all instances, I mean, we've had this conversation many times at this press conference on previous weeks, testing and PPE, personal protection equipment, and hospitals and healthcare providers across Kansas, while not perfect, have been much more successful in recent times in acquiring what they need to care for patients who can now enter the hospital or enter the clinic or see the physician.
Yeah, go ahead.
Steve, I might make one comment to add to that. I read something yesterday, and I'm sorry, I don't remember the exact percentage, but the amount of healthcare spending that is down is significant, and that's going to cut across whether it's in this metro or Great Bend or Hayes. People aren't seeking healthcare. Maybe they're losing jobs or whatever, so that's had a big impact, and it would have a big impact on those smaller communities too.
I think it's one thing when you say, okay, I'm not going to have that cosmetic surgery, but let's say that your knee's hurting and your hip's hurting or you're having a little bit of chest pain. All those things are important things to go ahead and have addressed. And it's not, it really is, you don't want patients to have bad outcomes. And what we know is that strokes and heart attacks at home and death at home from those diseases are up. And so that's not the right outcome. And I want to emphasize again how hard our system, and I know all systems out there are doing the same thing, are working to make sure that patients are safe when they come in there. And I would just say to you, our work with infection control, our work with masks and gowns and gloves and facials, all those things, you think, well, that's scary to me. I see people in that all the time. But the reality is that's keeping you safe. And it's safer now from an infectious disease standpoint than it has ever been. And I say that because we've paid so much attention to trying to keep people safe, Dana.
Yeah, absolutely. You know, those are barriers, those gowns and those masks, so we aren't transporting something from another patient to you or your loved one, or from an employee who may not know they're ill, from an employee to you or a loved one. You know, that is a huge issue. Safety is a big issue. Well, should we be testing everybody then for COVID? Should we be testing all of our employees when they come in? We're certainly screening them, asking them questions every day. We're temperature checks. Everybody's wearing masks. You know, the question begs to be asked, well, do you need to be testing everybody for COVID every day? We don't feel that at this point that's the right thing to do, because that test is good for that point in time. It's not good for 3 days down the road or a week down the road. There's no evidence to suggest that there is, but the other main infection prevention measures that we're taking into consideration with the masks, with the goggles, with the gowns, and the strict adherence to hand hygiene, that's what's going to keep you safe, and that's what we're doing for our patients and our employees.
And I just want to say, you know, we have these chief medical officer calls, and everybody's suffering and struggling with the same thing. I think we're all starting to test every pre-op patient, and a lot of us are starting to test people, any admission that comes into the hospital, look for it, just to be safe about that. But I will tell you that all your healthcare providers out there, clearly I know that the University of Kansas Health System the best, but you know, whether you're at Olathe or Shawnee Mission or North Kansas City or Luke's or whatever, we're all working and striving toward that same goal. We want you to be safe. Next question.
Hi, it's Melissa with Channel 41. Bouncing off what Dr. Hawkinson just said, while you guys are doing routine testing at the hospitals, what about private businesses that are also doing that type of routine testing of staff, you know, including restaurants, in order to reassure the public that it's safe to go in there? Is that pushing out then a false sense of security?
That's a great question, Dana. I'm glad you got it, not me.
Well, you can add anything.
I will try to add
I'm sure
to
I'll
it.
miss a lot of details. You know, again, knowing the nature of this test. So the test that we're talking about is a nasopharyngeal swab, or NP swab. They're certainly coming out with easier tests to do, saliva.
Saliva is coming, yeah.
Which it's looking like it may be certainly reasonable. But still, that test, we're only looking at that point in time. It's really unclear, because we know that you can have the infection without having any symptoms. So, and we understand it's so easily to get infected. So that test is good for that point in time. There's nothing to say that 3 days down the line, or 7 days or 10 days, that you couldn't have a different result. And being negative at one point is not the same as being positive 7 days down the road. I think that it doesn't, I think it does add a false sense of security. I think there are other measures that you can take into place, such as screening with questionnaires, screening with temperature, also the proper PPE, things as simple as masks, as we have seen, recommended so that you protect other people from you if you're not having symptoms but are still able to spread the disease. So at this point in time, yeah, feel that doing just the PCR test on, and then how often do you test the employees? Is it every week? Is it every 3 days? It's probably not feasible to do that, but doing these other measures is probably a lot more reasonable.
So one of the things that came in through our media feed was a question whether our hospitals should be testing every employee. Yeah. Thoughts about that?
Yeah, I think that goes to the same issue as just, say, a restaurant or a bar or a store. But again, however, in the hospital, we do have other measures. We have strict adherence to PPE, masking, gowns, gloves, to protect every person. Employees are screened with questionnaires and temperatures when they come into the hospital. And then you get to the point, well, if you're negative today, does that mean you don't have to get tested for 30 days? Certainly we know that at any point in time you could come into contact with the disease out in the community, especially now as things are opening up and people are going to be interacting more and out in the public more. So at this point in time, there's not a lot of feasibility, and I think it probably is more of a false sense of security as we move forward, but we will continue to evaluate that as much as we need to. In addition, we're continuing the strict adherence to the PPE and the hand washing and keeping everybody safe.
Yeah, I don't have a lot to add to that. I think it's that's the challenge, isn't it? We can think you're safe at that one point in time, but whether you're still safe 72 or a week later is unclear. And since most people recover over a 2-week period, by 2 weeks, I don't know what it means. And I think it may make folks feel better, but I don't know if it's really better or not. So I think if we get salival testing with really rapid turnaround and with plentiful testing, that's a different question. I think, and I think that's a really good question to ask. Maybe we should all be thinking about that if we can get rapid salival testing, because there are side effects from a lot of brain biopsies.
Right, absolutely. And if there's an easier test, and we've always said, we would like a test to be available in every clinic just as an influenza test is, but we need to make sure it's accurate. So, if those things happen, and if it's not a brain biopsy, we're obviously using that pejoratively. And but if it's an easy saliva test, we certainly would welcome that test and would evaluate at that point. But the turnaround time is an issue. The media and the testing supplies are an issue, as well as the testing kits, and that doesn't even include the testing turnaround time, which can be 24 hours in some cases.
Yeah, I'll even take a nasopharyngeal swab if I have to at the rapid turnaround. I had influenza this year and had my flu shot, but had influenza. Thank you very much. Yeah. That's your fault. And I did give it. I think you gave it to me. We were both positive at the same time. I think that you get the rapid flu test, you get it back in 5 or 10 minutes. Mm-hmm. That's what we need ultimately to do the kind of thing where we're going to test a lot of employees. So, okay, next question.
Hi, I have a question for the senator. Somebody was asking what is being done to help increase testing in Kansas?
That is a question that is prevalent and has been for weeks. First of all, I would say that we have, the country was not prepared in this regard, and all the tests that were capable of being taken out of storage, found across the country that we could claim entitlement to in Kansas have been delivered, and the focus is now shifted to the private sector. And almost every day, certainly every week, I have conversations with business owners, with business managers, people who are shifting their production to the capability of manufacturing tests, and more tests are coming. One of the things that we were able to utilize the presidential executive order dealing with meat packing plants, with food processing, was the ability to insist that we get greater priority, because so much of the testing decisions are now made by FEMA and the Department of Homeland Security, how they're distributed, the emergency preparedness decisions. So we have manufacturers in Kansas that we would love to have their tests in Kansas, but they are being sold and utilized elsewhere. The designation of food processing by the executive order allowed us to get more tests into Kansas. But I think the answer is every day there is more tests being developed. The swab, it's not always the test. You also need the laboratory. You need the swab. You need the reagent, the chemical that the test is transmitted in. And there's shortages in various places in one or more of those things. And no particular circumstance seems the same to me. People can have the testing capability, but then it takes too long to have the laboratory report obtained, or you don't have the swab, or you don't have the reagent. Nothing seems to be the same in every community or circumstance, but that is changing and improving, and it just is taking time to accomplish that goal. When we learn of a source of tests, our normal course of action is to notify the Kansas Department of Health and Environment, to notify the Kansas Emergency Preparedness Department, but much of this now is being handled in the private sector with healthcare providers, businesses, and others acquiring the tests and the ancillary things that go with those tests themselves.
Thank you, Senator. Other questions?
Yeah, this is Mike from KCPT. I wonder if you all can address, I mean, we are having more testing, and I wonder if you can address kind of the misperception that gives when aggregate numbers are reported, when, you know, the largest spike in one-day spike. I mean, that's a little bit misleading because we're testing more. I mean, how do you get an accurate count of the prevalence when you're just testing more?
Yeah, that's a great question, and Doc Hawk here and I could try and take that on a little bit. You know, it's a kind of a testing whirlwind. We've not only are we testing more, we're testing differently. And those two things make early results, or results from 2 or 3 or 4 or 6 weeks ago, harder to interpret relative to in things today. So we're testing more. We're testing more the general public, but we're also testing more specific populations, be it a meatpacking plant or a prison or places where we think there's an outbreak. And because we have more tests to use, we can go find out if there are more outbreaks. And so it's kind of a hard thing to interpret. You almost have to look at a day's test results as a standalone day, and the temptation is to constantly compare it to day from a month ago, and it's hard to know because our testing strategies were so different a month ago, so that the results are difficult to compare. And there are two schools of thought out there. One is that yes, we are testing more, but we're seeing more positive results than we did before. The other is that okay, we're testing more, we've been seeing more positive results for quite a while, but we're not seeing more people in hospital beds. We have out in western Kansas where clearly there's been, the coronavirus we knew is going to move from the more urban areas to the more less populated areas. But overall hospitalizations are not spiking to some high number. So I think, Dana, that there's both testing strategy, testing numbers, and then there's testing results. Other thoughts about that?
Oh, yeah. Our testing strategy has evolved since day one with were you a contact or were you in China to do you just have a loss of smell or taste? Our testing strategies have just changed so much on what we're calling symptoms that, things that we're doing now were not considered symptoms of illness back then. So I think testing strategies is very important. We are trying to go out and test more of the general population who may not be having typical symptoms. But the other issue is also the rate of positivity. So all the tests that we're doing, we're looking at what is that rate as well, and is that rate going up? But that just goes to everything that Dr. Stites was talking about. So I would agree, yeah.
Yeah, I think it's easy to look at all the numbers and see gloom and doom. What I would say is you should look at all the numbers and see caution. The rule for us should be that the things we've done to bend the curve have really bent the curve. And even as we open up, we have to do that thoughtfully and cautiously. It doesn't mean you don't go out in public, but it does mean that when you go out in public, you should wear a mask, you should wash your hands, you should not touch your face, you should cough into your elbow, and you shouldn't be sick when you go out. Those are the things that can help us from having that curve accelerate again into a dangerous zone. And I think that's really, if we're going to take anything away from all this testing data, it should be there's a lot of people with coronavirus, a lot of coronavirus out there. The way you stay safe, ultimately, is to keep your distance. It doesn't mean you can't go out. Right. It means when you do it, you have to do it purposefully and with personal responsibility.
Right, because I think that those places of work can also be microcosms of places we may go in society because they are together. There's a lot of people together for some amount of time, and that can just show you that how hyper contagious this disease can be and can spread so easily.
Yeah. Next question.
Sorry, this is Nate. I do have a question for you. I have a nurse, most likely not with our health system, who was concerned about overall, like furloughs overall, due to the decrease healthcare GDP. So that may be a question more for the senator.
Yeah, we know that's something we've had to take on. I'm going to first turn to Doug Gaston because, we've thought, gosh, do you furlough people or not? But we still think people are going to come back to healthcare. And once you don't have people, then you have to rehire them. You've already got a great workforce. You don't want to let those people go.
Yeah, I might, if I can tag onto that. We've developed plans, and we've got different scenarios we're playing out. If we could predict how long this lasts, we could do better planning. But in the interim, we've got to be nimble with our plans. In doing that, I think it's short-sighted to dismantle your workforce. We're in business, and we are a business, believe it or not. We're in business to treat patients. To treat patients, we have to have highly skilled workers. These providers and others that support them are highly skilled. And to let them go or furlough them and possibly not get them back really damages our business model. So we can't do that. So I can tell you that we've got plans. Nowhere in those plans is a plan to reduce staff. There's lots of other areas we can be more efficient in, but that's one that I think will harm us in the long run.
And one of those things is having people feel like it's safe to go get care. You know, one of the tragedies of this COVID story, I think, as we look back on it historically, will be that not only did a lot of people die from coronavirus, we're going to find a lot of collateral damage from people who didn't get health care. And it's not a plea to come spend money. You got to understand that, because we're not here to have you spend money. We're here to take care of you. We didn't go into health care to try and do things that were unnecessary to patients. And, you know, there was a whole epidemic of that maybe in the 90s and early 2000s. I mean, you just, if you do things unnecessarily, A, you don't get paid, and B, now you pay a penalty. So when people get readmitted to the hospital because we didn't do it right, we take a penalty for that. So we really try hard to do the right thing. And, you know, both around our people and around our patients, don't be part of the COVID collateral damage. Don't let it get you because you're afraid to get help.
Steve, I might comment. It seems to me, since I've been here, that, you know, we have a great responsibility in the hospital and the health system, and that responsibility is to take care of the patients. If we dismantle a workforce, we can't fulfill that responsibility. And I think if we're actually part of the community, we have a responsibility to our employees to the extent we can to preserve their employment, and that's what we're going to do.
Senator, I know you've been having to take on this question nationally and here in this state. And again, we can't tell you how much we appreciate your support around that.
Well, it is a couple of thoughts. It is what you've been talking about in this press conference about the desirability, availability, the necessity, perhaps is the best word, of patients returning to their healthcare providers. So we can reduce the likelihood that someone in healthcare would be furloughed as the revenues are regenerated, that the revenues return. Again, you made the point clear, it's not for revenues solely. Perhaps not, you would say not for revenues at all. It's for the care that patients need. But when that care is provided, it means that revenues are flowing again to our healthcare providers, and it reduces the necessity or even the likelihood that someone who is in healthcare would be furloughed. So as we have more ability to be out and about, and as you described, healthcare providers, KU that you know the best, being safe to return to, it means that we are increasing the chances that the necessary resources are there to keep healthcare providers employed. Secondly, this PPP program that I mentioned earlier, the Paycheck Protection Program, is designed to keep people employed, including people who can't come to work physically because of a stay-at-home order, or can't come to work or can't work at all, even at home, because of COVID. Somebody in their family, themselves, have the virus. So this Small Business Loan Guarantee Program was designed to reward employers who keep their employees on the payroll, even though they may not be physically present at their work site. And that is an important component in, again, it's a healthcare plan and it's an economic plan. And part of the success of that program will be that it keeps employees and employers, that relationship continuing. So while it's challenging probably everywhere to recruit necessary healthcare workers, it is especially a challenge in rural Kansas. And we do not want to lose anyone that we have spent time, effort at recruiting to come to our small towns and to perform medical services to the community. We don't want to lose anybody during COVID-19, and this helps us keep those staff in place. And in this case, if the hospital keeps the staff employed, then that loan is in large part forgiven, and it becomes a grant. It rewards and encourages, and in many cases enables, the hospital to continue to employ the specialty employees that they have that are necessary. In many communities, that's a nurse. In some places, it's other things, but keeping that relationship alive and well and keeping the finances such that paychecks can be written is an important component of this program, and why it was so critical to get community hospitals, less than 500 employees, to be eligible for so-called PPP.
Thank you. Other questions?
Yeah, Dr. Hawkinson, would you be able to, it's interesting the role that these surveys play. I mean, you would think that you know, interventions are more about tests and things like that. Can you talk about how important just these surveys are in preventing the spread?
Are you talking about test surveillance?
Well, no, I guess I mean the questionnaires. The questionnaires when you're asking people, when you talk
Right.
about that's what I mean.
Yeah, you mean when patients come in and they get a survey about whether they're safe or if they've had if they're sick or not, or if you
Right.
go
I
to
mean,
business.
just how that you know, verbal stuff can really is part of the I guess the changing testing regimen or
Requirements,
the different
yeah.
questions.
Yep.
Yeah, well, that's certainly the first step, because we know that most everybody will have symptoms from this disease. There's very few people, 2 to 3% in some of the Chinese publications and some of our recent publications, that will not have any symptoms ever. So we know that most people are going to have symptoms, and most of those, a majority of the people will have symptoms 5 to 7 days from infection. So the screening, the questionnaires is the first step, and we've expanded that number of symptoms from traditionally it was just fever, cough, and shortness of breath. Well, now we know there's at least 8 other symptoms that we also ask in conjunction with. So symptoms is going to be the first step, asking those questions for anybody who's coming, whether you're a visitor, a patient, or an employee. That's going to be the first step. So that will help hopefully screen people out on a regular basis, but in addition, we're also going to be having somewhat of a source control by having people wear masks, patients, employees, things of that nature. And doing those types of things, you will hopefully capture many of those asymptomatic people and reduce the risk of spread from our visitors, from our employees, and from our patients as well. And I don't know if Dr. Stites has anything to add
No,
to
I think
that.
that's right. I think, you know, the other thing it does is it discovers people who have other illnesses.
Yep.
And that's a good thing, because you know, there's, though influenza has largely tapered off, there's still rhinovirus, other forms of coronavirus, and RSV and stuff like that that's out there, and you want to know that.
Absolutely, and I've always said we are either in influenza season or respiratory viral season, or we're ending it. And soon we are going to be back into respiratory viral season. And it's a good thing that you brought up about influenza vaccination. So as we move into September, October, November, we are going to encourage everybody to continue to get their influenza vaccine.
Now more than ever. More than ever.
And here's why. So there was a publication that was touted on a recent video that was put out by an independent group. And the publication was actually very good, but what they talked about was, well, it increases your risk of coronavirus.
Which is not true.
So what we would like to say to that is that publication was actually very good, and if they've kind of hijacked the results, but if you go in and read that publication, what it shows is that it actually decreases your chance of influenza by 50%. It decreases your chance of getting every other infection with influenza, meaning co-infection, by more than 35%. So it might have increased your risk for coronavirus, and these are typical coronaviruses. These are our cough and cold coronaviruses that we know of. You know, by maybe 30% relative risk, but what it did was reduce your relative risk for 6 other viruses. So that wasn't really mentioned in the video, but what we'd like to say is that influenza vaccination, while this one study did show that, it's not causality, but what it does is overall reduce your risk of, you know, at least 5 or 6 other virus infections, and especially co-infection with other viruses should you get influenza. So we are going to continue to promote influenza vaccination. It's going to do more good than anything, hopefully keep you safe and keep you from getting ill. So,
Yeah, and plus, one of the problems with epidemiological data like that is if you're not sick with influenza and home, you're more susceptible to another virus because you're back out in the public again.
Right.
So, I mean, it's one of those things like, okay, well, that may not be entirely the way to look at that question. So you have to be very thoughtful about how you do it. Okay, one last question. Who's got?
Well, I have one since nobody else is speaking up. I have a viewer who is asking about the possibility of inhaling carbon dioxide because of the mask. Is that true? And is that something that we should be concerned
I
of?
would not be concerned about as a pulmonary physician. I'll tell you, you're still going to entrain oxygen from the atmosphere and get rid of the CO2 that you exhale. If you have really bad lung disease, the mask can be a problem, but only because it adds to your work of breathing. It's not so much a CO2 issue. So I would tell you that that is not a concern, but it's a good question.
yeah,
But thank you.
absolutely.
Well, as we wrap up today's show, Senator Moran, thoughts that you would like to leave us with that you know are important?
Well, I appreciate the chance to join you, and I learn a lot from these conversations from the two doctors and their guests, and I'm appreciative of the efforts that the University of Kansas Health System is making to provide information to Kansans and folks in the Kansas City region. So thank you very much. When I leave this call, I'm participating in a discussion with leaders in Southwest Kansas, including those communities that have meat processing plants. Again, focused on trying to be helpful to the people who work there so that they are safe and know they are safe, but also to try to be helpful to Kansas livestock producers. We need markets for what we produce in agriculture in Kansas. And we also know that we want our consumers, people who go to the grocery store, to be able to find grocery stores and restaurants now to be able to find Kansas beef on the plate and in the aisle. So appreciate the chance to join you. I'd shout out to my staff, and particularly Tom Brandt, who's a Prairie Village native, was successful in his relationship with Taiwan. And Taiwan is donating 100,000 masks to Kansas, and just another example of where there is an opportunity for us to take care of each other, not only here in the United States, not just here in Kansas, but in this case, a donation from Taiwan. And while I'm skeptical sometimes about medical devices and products coming from China, Taiwan and Japan and other places have the quality and the requirements for that quality the same as the United States does. So thank you to the folks in Taiwan for choosing Kansas to help, and thanks to Tom for his efforts to make sure that they knew that we could use that help.
And Senator,
great to be with you, and hope next week is a good report.
Well, we hope so. And Senator, thank you for your help and your aid to health in all of Kansas, too. And thanks to all our local donors who have helped step up into these things. And indeed, we know that the things that come out of Taiwan, Korea, and some of our other things are really good quality. Doug Gaston, things you want to leave us with this morning?
You know, one of the things as I'm sitting here listening, this is a pandemic. It is kind of crisis management. We're not used to this. Thing I've noticed in the last 8 weeks is it really has, in a strange way, pulled people together, and the cooperation in the community. You mentioned the donors, Senator Moran, with the physicians and others here at the hospital is really, and the community is really encouraging. So I think together we're going to get through this.
I think together is the key message.
Yeah. As we move forward, we want to continue to promote, discuss with your medical teams. We want you to continue to treat your chronic illnesses, your lung disease, your heart disease, but your diabetes as well. Particularly, we've talked about heart attacks and strokes, but there are also people with diabetes who have wounds who may not be able to get them treated as they normally would, and those can lead to amputation, and we don't want that either. So there are a lot of chronic illnesses that we're talking about. Please discuss with your medical team. Please continue to treat those optimally so we aren't having those emergency situations.
Yeah, I think this together thing is really important. Whether you're a Republican, a Democrat, an independent, or a Martian, my family thinks I'm a Martian, pandemics are bad. Pandemics are new to us. They're not new in human history at all. People think, well, the virus came from here or there. No. Pandemics are a routine part of history on our planet. It's just that this one is new to us because it's been over multiple generations since we felt it. Pandemics are bad, pandemics are hard, and pandemics are new to us. But pandemics can be beaten, and the way they are beaten is by you taking good care of yourself. And the way you do that is that you wash your hands, you don't touch your face, you can say it with me, you cough into your elbow, you don't go out when you're sick, you wear a mask, and you don't ignore yourself. Don't ignore those symptoms that would lead you to get health care. Don't get hurt, don't die of something else because you are afraid of coronavirus. It is not a superhero or a supervillain. It is beatable by the things we know to do. So take care of yourself. When you can, stay home. There's still no place like home. But most of all, stay safe. We'll hear from you and we'll see you next week. Thank you.